Welcome back, ladies and gentlemen. We now commence the afternoon session, starting off with the fifth symposium for the day on pleural disease. I would now like to invite the chairs for this session, Consultant Respiratory Physician Dr. Afla Sadikin and Consultant Respiratory Physician Dr. Chandimani Undugodage, to introduce the speakers.
Yes, good afternoon. Welcome to the Symposium on Pleural Disease. And to start off, we have Dr. Damit Nandadeva. He's no stranger to this audience, Consultant Respiratory Physician from Teaching Hospital Kegol, to talk about how to approach a unilateral pleural effusion.
Good afternoon. Welcome back from lunch. I think I've got a daunting start off with a daunting session here right after lunch. Hopefully I can keep you awake and hand you over to Professor Lee afterwards. So let's crack on. First lecture is on how to approach a unilateral pleural effusion. So I think we all know that pleural effusions are common, and there's a widespread etiology. Over 50 to 60 different etiologies have been described. Pleural effusions can occur as a result of diseases localized to the pleura, such as mesothelioma, underlying lung diseases like lung cancer, pneumonia, etc., systemic conditions like connective tissue disorders, SLE, rheumatoid arthritis, a multitude of drugs, and organ dysfunction, which is a common cause of pleural effusion. Most commonly heart failure, renal disease, and liver disease. And what's interesting is that up to 30% of pleural effusions can actually be multifactorial. So in some instances, even if you have a suspicion of a reasonable diagnosis, especially if it's a unilateral pleural effusion, you may well need to investigate to find the actual etiology. And the aim when a patient with a pleural effusion presents, especially a unilateral pleural effusion, is to arrive at a swift diagnosis so that we can initiate treatment. And because the etiology is widespread, we need a systematic approach. And the other important thing is to minimize unnecessary invasive investigations and focus on the most simple initially. So here we'll quickly have a look at a modified algorithm. It's a simplified algorithm for investigating a unilateral pleural effusion. When a patient presents, the history, examination, chest X-ray, and baseline investigations are very important, especially to point towards a possible etiology. And it's based on that will be guided along the pathway to further investigation. The next step is usually an ultrasound-guided diagnostic aspiration and to send off the pleural fluid to have a look at the pleural fluid biomarkers. Here, using Light's criteria, which we'll have a brief look at later on, we can categorize into exudates and transudates. Transudative causes are usually as a result of organ dysfunction, and these underlying organ involvements can be treated. If it's an exudate, we will need further investigation with detailed imaging. And if cytology negative, we will need to go for some sort of biopsy for a firm diagnosis. So when we talk about the history, examination, and so on, even in this day and age, history and examination are very important. You may have a diagnosis based on your history and examination. Even otherwise, it will definitely point towards the correct pathway. And when we focus on this, we need to ask about comorbid conditions, especially heart disease, underlying lung disease, renal disease, and liver disease. Look for features of infection, contact history and risk factors for tuberculosis, previous history and risk factors for other malignancies. Medications are important, recent procedures like thoracic surgeries and so on, and miscellaneous causes like connective tissue disorders, thyroid disease, and pancreatitis can also result in unilateral pleural effusions. Along with this, a chest X-ray is mandatory, obviously, and baseline investigations to look for organ dysfunction, cardiac function, renal function, tuberculosis are also additionally important, and your subsequent investigations will be guided based on these. So once you've arrived at this point, the next step is to try and go for a definitive diagnosis. So the first investigation of choice will be ultrasound-guided pleural aspiration. And for unilateral pleural effusions, an ultrasound-guided pleural aspiration is recommended in almost all cases. I suppose the exceptions would be if there was insufficient fluid for aspiration based on ultrasound, say less than 1 centimeter depth at the point of the diaphragm, or if it's a definite parapneumonic effusion and it's quite small. In this case, you may wait and watch, but in all other instances, the recommendation is to go for a diagnostic pleural aspiration and try and arrive at a firm diagnosis. So here, when we talk about pleural aspiration, we can, when the patient first presents, we can either go for a diagnostic aspiration or a diagnostic plus therapeutic pleural aspiration using an aspiration kit. If you took part in our pre-congress workshop, I think we would have demonstrated all of these pleural procedures. The decision whether to go for a diagnostic tap or a therapeutic aspiration is based on the amount of effusion, the patient's symptoms or clinical condition, and also whether the etiology of the effusion has been identified previously. For example, if the patient is presenting to you first time with, say, a moderate effusion, it's better to leave fluid in there for subsequent investigations in case you do not arrive at a diagnosis based on pleural fluid analysis. In this situation, we can go ahead with a therapeutic pleural aspiration, drain about 1 liter off. This can be done as an outpatient procedure under ultrasound guidance. We can send the fluid off. If it is non-diagnostic, we have enough fluid left for further investigations down the line. Symptoms due to pleural effusions are multifactorial, and I think one of the most important things is the dynamics on the diaphragm as well, which we do not have time to discuss now. But even removing 1 liter, 1.2 liters at a time can improve patients' symptoms significantly in the short term. So we do not need to insert drains at this point, but we can just aspirate. And the recommendation at the moment, based on BTS and other guidelines, is that bedside transthoracic ultrasound is essential for any and all pleural procedures. So this is very important. There is definite evidence that it reduces the risk of pneumothorax and improves the rate of fluid sampling as well. So this is now mandatory, basically. In addition to the reduced risk and increased effectiveness, point-of-care ultrasound can also provide images and details regarding effusion size, position, presence of loculations, underlying pleural masses, and so on, which can guide investigations. So here we have an image showing the diaphragm here and a loculated pleural effusion here. So in this sort of situation, in the way the patient presents, we can possibly determine that this may be a complicated infective origin pleural effusion or an empyema based on ultrasound. So it is very useful in addition to the safety aspect. When going ahead with pleural aspiration, there's a few important precautions to take as well, especially in anticoagulated patients. The recommendation is to avoid procedure if the platelet count is less than 50,000, INR is high, or if the patient is on warfarin or DOAC, or treatment dose low molecular weight heparin. But we can always withhold these medications, correct any clotting abnormalities, and then safely go ahead with pleural aspiration. In actual fact, even with marginal parameters, the risk of bleeding with ultrasound-guided aspirations has been shown to be very low. But it's always better to be safe. Once a pleural aspiration is performed, how much fluid to send off? For analysis of cytology for suspected malignancy, at least 25 to 50 ml should be sent off for best results. If less than 25 is obtained, then it may be worthwhile to repeat the procedure and send off additional fluid, but generally more than this is not necessary. And in suspected malignancies, it's always better for the specimens to be processed by direct smear and cell block preparation as well for maximum yield. For suspected pleural infection, it's important to send the fluid off in aerobic and anaerobic blood culture bottles in addition to sterile containers as well, again for maximum microbiological yield. In all patients, we generally send off the following routine biomarkers, that's cell counts and differential, total protein, LDH, glucose, and cholesterol. Based on some of these criteria, we can identify whether a pleural effusion is an exudate or a transudate. And one of the parameters that we can use is Light's criteria. Here, there's 3 criteria. If any one of them are positive, then we can take it as an exudate. And it's based on the pleural fluid protein, serum protein ratios, and the pleural fluid serum LDH, and so on. An important note is that even with Light's criteria, especially in patients with heart failure treated with diuretics, up to a quarter of transudates can be misclassified as exudative effusions. And in this sort of situation, calculating the serum to pleural fluid albumin gradient rather than the ratio may be more useful. One additional note is that up to 10% of transudative effusions based on Light's criteria have been shown to result in a malignant etiology later on down the line. So if there is any clinical suspicion, or if the clinical radiological parameters do not tally with your Light's criteria, it's always better to be cautious and investigate, even if it seems like a transudate. So just to briefly go into causes, based on Light's criteria, exudative causes, the most important and common are infection and malignancy, and this is basically why we need to investigate essentially all unilateral pleural effusions. Apart from that, there are a variety of other miscellaneous causes. When we take transudates, it's mainly, the vast majority is cardiac failure, even if it's a unilateral effusion. Most of the time, transudative effusions are bilateral, however, and the history examination and the initial investigations will probably reveal a cause in this sort of situation. Once we've done the initial pleural fluid general biomarkers, we've got a few more that will support a firm diagnosis. One of the most important is pleural fluid cytology to diagnose malignancy. The sensitivity overall is quite good. It's up to 60%, with variation depending on the type of cancer. And because the procedure is less invasive and relatively effective, it should be a first-line investigation when investigating suspected malignancy. In comparison, pleural fluid tumor markers do not provide increased sensitivity over cytology. The sensitivity is much less, so generally not recommended. What about tuberculosis? So for tuberculosis, we can do pleural fluid adenosine deaminase or interferon gamma levels. Both are quite sensitive and have good specificity as well. And the recommendation is that in high prevalence populations, either ADA or interferon gamma can be considered for diagnosing tuberculous effusions. And in low prevalence populations, ADA can be used as an exclusion test for pleural TB. When it comes to ADA or interferon gamma, the cost for ADA is less. So with reasonably similar sensitivities and specificities, I think, especially in our setting, it's better to go for adenosine deaminase. Pleural fluid ANA, antinuclear antibody positivity, supports a diagnosis of lupus pleuritis, so may be useful in specific situations. In heart failure, both pleural fluid N-terminal pro-BNP and serum N-terminal pro-BNP are elevated. And there is no advantage to using pleural fluid. So you can just go ahead with clinical factors, echocardiogram, and if necessary, serum BNP rather than pleural fluid. And there's a few other diseases that can be confidently diagnosed with pleural fluid biomarkers as well, but we won't go into detail. When it comes to pleural imaging, we've talked about ultrasound. CT is also useful, not necessarily in all patients, but especially when the etiology is not obvious based on what we've discussed so far. The effusion is complex or loculated and may need to go down the line for surgery. If malignancy is suspected, or if pleural aspiration is unsafe or the patient declines. And in this sort of situation, especially if you're suspecting malignancy, it's always better to go for a CT, contrast CT of the chest, abdomen, and pelvis. And if it's just a CT of the chest, then ideally pleural phase contrast enhanced scans to show pleural pathology. So here we have a few features of malignancy on this slide: mediastinal pleural involvement and a definite pleural nodule, which are more suggestive of pleural malignancy. And in infection, you can see a lentiform configuration, the split pleural sign or the visceral pleural thickening, and underlying pulmonary consolidation as well. But CT is not diagnostic of pleural effusion of etiology, and the sensitivity is poor, so we will need to go for cytology or biopsy in most cases. PET is more sensitive than conventional CT, and along with other criteria, especially if it is not possible or the patient declines further tissue investigation, we may be able to give a reasonable diagnosis, especially in malignant pleural disease with PET-CT. The clinical value of MRI in this regard is yet to be determined, though. Now, we've talked about history examination, pleural aspiration, pleural cytology, investigations for TB, and imaging. But in some cases, we do need to go for pleural biopsy to obtain tissue for histology and tuberculosis as well. So there are several methods to obtain tissue. One is medical thoracoscopy or local anesthetic thoracoscopy, which can be performed by pulmonologists under local anesthetic and sedation. Video-assisted thoracoscopic surgery, which is performed by thoracic surgeons under general anesthesia, or image-guided biopsy, which can either be CT or ultrasound-guided. These are all very effective. And let's have a quick look at a comparison. So medical versus surgical thoracoscopic biopsy, the evidence suggests that they are both equally effective. There's no difference in diagnostic yield, sensitivity, or specificity when it comes to diagnosis of malignant disease or tuberculosis. So they're equally good. You can be guided by availability and operator skill and so on. What about thoracoscopy, either surgical or medical, versus image-guided biopsy? Here, obtaining biopsies under direct vision of thoracoscopy is better for definitive diagnosis and yield. And thoracoscopy is definitely better than blind close biopsy with an Abraham's needle or a cutting needle. When it comes to image-guided biopsies, both CT and ultrasound-guided biopsies, if the operator is experienced, there is no difference in obtaining definitive diagnosis, so either is fine, and it should be based on the operator, the radiologist concerned. And obviously, image-guided biopsy is better than blind close biopsy. So in summary, when it comes to obtaining a biopsy, the method that you use can be guided based on local availability and also the clinical indication and the patient preference as well. Generally, local anesthetic thoracoscopy, as the name implies, does not require general anesthesia, so may be preferred. And Thoracoscopy can be preferred over image-guided biopsy, especially if the pleural effusion needs to be managed as well concurrently. So I think Professor Lee will discuss further when it comes to malignant effusions. Right after thoracoscopy, after taking biopsies, we can insert an IP intrapleural catheter and either drain the fluid off gradually or can use talc concurrently as well and try and attempt for pleurodesis at the same time also. So I think he will discuss more regarding this. So if there is a need for control of the pleural effusion, then thoracoscopic procedures are likely to be more useful. General consensus is that in this day and age, blind biopsies should not be performed, especially if we are suspecting malignancy. In tuberculosis, the involvement of the pleura is more generalized. So in a resource-poor setting, we may still consider it, but image-guided biopsies are much more superior. And final couple of slides. I think increasingly we are moving to a day and age where pleural disease evaluation especially is managed in an ambulatory setting in a one-stop clinic where the patient comes in with the imaging and undergoes initial investigations on the same day and has planning for subsequent investigations on the same day as well. So it reduces delay, streamlines care, and reduces cost and risk of infection as well. Finally, my key messages are that malignancy and infection are the common important causes of unilateral pleural effusions. Therefore, they almost always need investigation, and it should be in a systematic manner so that we can arrive at a confident diagnosis. Thoracic ultrasound is now mandatory for pleural procedures, especially with regard to safety and effectiveness. And increasingly, ambulatory one-stop approaches are being preferred for patient convenience and cost benefit as well. Thank you.
Thank you very much, Dr. Damit Nandadeva, for that comprehensive talk on approach to a unilateral pleural effusion. So it's my great pleasure to invite Professor Gary Lee, who is not a stranger to Sri Lanka and to our respiratory fraternity. So Professor Gary Lee will be talking about management of malignant pleural effusion. He is going to give us an update. He is a professor of respiratory medicine in University of Western Australia, Australia. Over to you.
Good afternoon. And my sleep medicine colleagues always tells me that the audience is most likely to fall asleep between 2 to 3 p.m. And for the last 4 or 5 conferences, I was always drawn to speak between 2 to 3 p.m. So I've learned from one of my co-speakers in a recent American conference that he asked the whole audience to stand up and just stretch your legs for 5 seconds before we start my talk. Can we all do that? And then if you don't stand up, I'll count you as fallen asleep. And the chairs as well. Thank you so much. Okay, great. Now, if you fall asleep, that's my fault, not the previous speaker's fault. Good afternoon, and thank you for the opportunity to come to Sri Lanka again. And my job today is to talk about malignant pleural effusions. Malignant pleural effusion is a major healthcare burden. Now we've got some number from the United States to wrap around it. It causes about 125,000 hospital admissions a year, with a total hospital inpatient care cost of over 5 billion. Breathlessness is the most common symptom for presentation. In the limited time today, I'm going to focus how I manage malignant pleural effusions that might be different from other centers and why. Breathlessness, as we heard, is the most common symptoms. And this is a paper from Eleanor Misha, who collated 550 patients with malignant pleural effusions from 5 randomized trials, 2 of them from my group. And all these patients in the trial has had their breathlessness recorded using the 100 millimeter visual analog scale. And on this scale, on one end, it is anchored by no breathlessness at all, and the other end by worst breathlessness possible. And she found that those who have more breathlessness at the baseline and those patients who have more breathlessness in the 7 days after drainage have poorer survival. And when we divided those 550 patients into 4 quadrants, and this is the Kaplan-Meier survival curve, those who have the worst breathlessness also has the worst survival. So breathlessness is not just a symptom, it's a very useful biomarker of how these patients will perform. So why are patients with pleural effusion breathless? So we are very interested in this, and then my group has been performing a series of studies called the Pleural Effusion and Symptom Evaluation, or PLEASE studies, to look into why patients are breathless. The first of that is published in the ERJ. It's the most comprehensive study of patients with symptomatic pleural effusions. It includes 150 patients, 145 evaluable. 2/3 of them were malignant, and these patients has a median amount of 1.7 liters of fluid drain. So they're not small effusions. And not surprisingly, the breathlessness score improved out of 100 points from 40 to 75 as a group. And the functional level on the 6-minute walk test also improved from 244 to 292. But we know that only 3 out of 4 patients had symptomatic improvement. On the multivariate analysis, those who were more breathless at the baseline and those who have abnormal diaphragmatic movement before drainage on ultrasound were more likely to improve. Now this is important. If we look at the physiological parameters and lung functions, we actually find that the respiratory rate after draining a median of 1.7 liters only marginally improved, and so is the heart rate, and the oxygen level hardly changed after draining all this fluid. Many smaller studies have shown it before, and we just confirmed that the FEV1 and FVC only improved by about 20 or 25% of the volume of the fluid you drained. So what does that mean? It means that breathlessness from pleural effusion results not from hypoxemia, but from increased work of breathing because of altered respiratory mechanics. And because of the lung volume changes, we know that the lung compression is not the key to how the effusion is accommodated. So how does the pleural cavity accommodate the many liters of malignant pleural effusions? So this is a patient whose chest X-ray shows a complete whiteout on the left chest from EGFR positive lung cancer. But what you can't appreciate on the chest X-ray, but you can on the CT scan, is how this patient accommodates the many liters of fluid. The first thing that would happen is that the diaphragm becomes flattened and then everted, and in this case pushed down right to the kidney level. If you look at the rib spacing, there is a hyperinflation unilaterally. The rib spaces are a lot bigger on this side than the other side. The lung is compressed and the mediastinum is pushed to the other side. These factors join together to help to expand the hemithorax to accommodate this fluid. But these changes alter the respiratory mechanics and makes patients breathless. But don't just think about the volume, it's also the weight. 1 liter of pure water is 1 kilogram, and malignant pleural effusions in general is about 10% heavier on specific gravity than pure water. So this person who has 3 liters of malignant pleural effusion will have up to 3.3 kilograms, like these dumbbells, sitting on his hemidiaphragm that he has to lift up every breath, 12 breaths per minute, 24 hours a day. And this contributes to the symptoms. What does it mean to your daily practice? This patient has got significant trapped lung, but do bear in mind it's the weight of the fluid on the hemidiaphragm that contributes to the breathlessness. So even though the patient has trapped lung, even if the underlying lung does not expand, drainage can still relieve symptoms in a lot of these patients, and they should not be excluded without giving a trial of drainage to see if drainage is beneficial. This is an important slide. Every week, my fellows will be asked by other services to go and drain people's pleural effusions because the patients are hypoxic. If a patient has significant hypoxemia, it is not due to the pleural effusion. Always look for an alternative cause, even in the presence of a large pleural effusion. This is a real-life example. This patient is known to our service with lung cancer and prior malignant pleural effusion. previously has pulmonary emboli, IVC filter is on NOAC, and he presented via ambulance to the emergency department, very hypoxic, very distressed in a para arrest state, with this chest X-ray, which of course shows large pleural effusion and contralateral mediastinal shift. And I think in most other emergency departments, they would have urgently put a drain in. But in my hospitals, they would always ask me first. And I said, no. This type of presentation and this level of hypoxemia is not due to pleural effusion. You need to look for alternative causes. So we intubated the patient and we took him to CTPA, and sure enough, he's got a massive central pulmonary emboli. He's already fully anticoagulated, so our very clever interventional radiologist did a clot retrieval, and these are all the clots from his central pulmonary arteries. And his physiology immediately improved on the table. We did drain his effusions. Eventually, he was extubated the next morning. So after PLEASE 1, we went on to PLEASE 2, which is the hard work of Sanjeevan Muruganathan and Deirdre Fitzgerald, two of my fellows. Remember, the diaphragm is one piece of muscle. So in PLEASE 1, we show that the weight and the volume of the fluids affects the ipsilateral hemidiaphragm. So the logical question is, what happens to the contralateral hemidiaphragm? And this has never been investigated before. To cut a long story short, this cartoon summarized the findings. In the ipsilateral side, with the pleural effusion, the diaphragm moves a lot less. But at that same time, if you use ultrasound techniques to actually measure the diaphragmatic movement, the contralateral hemidiaphragm moves excessively on the opposite side to try to compensate from the reduced movement ipsilaterally. And once we drain the effusion, the ipsilateral hemidiaphragm returns to normal, and the hypermobility of the contralateral hemidiaphragm also returns to normal. So the important finding of this study is that for the first time, we show that when you have a pleural effusion, it does not just affect your ipsilateral hemithorax. It has implication on the contralateral hemithorax as well, which means that if your patient has got a diseased lung or unhealthy lung on the other side, they are going to suffer a lot more in breathlessness. Think not just the impact on the ipsilateral, but also contralateral hemidiaphragm. So in patients with bilateral pleural effusion, that compensatory ability of the contralateral side is lost. So the effect on breathlessness is a lot more profound than just the sum of two ipsilateral effusions. So 1 + 1 = 4. So in these kind of patients, I would try my best to keep one side dry, such as with indwelling pleural catheters. So how do I manage malignant pleural effusion in 2024? Obviously, you need to see how long the patient is going to live, how many times you're going to likely to drain. But for the patients with recurrent symptomatic malignant pleural effusion, your options are thoracoscopic VATS TALP purgage, TALP slurry through chest tube, and indwelling pleural catheter, as the previous speaker has mentioned. There's going to be a surgeon talking about it, so I'm going to preempt you and tell you that there has been 4 randomized trials so far for comparing thoracoscopic TALP purgage versus TALP slurry through chest tubes. And all 4 studies, totaling about 1,000 patients, did not show any advantage of thoracoscopic TALP purgage over TALP slurry. And this is the largest study done by the North American surgeons, led by Caroline Dressler. And this is a Kaplan-Meier analysis of the amount of patients that still got good pleural fluid control up to 6 months. And there was no difference between the TALP slurry and the TALP insufflation arms. My colleagues in UK repeated the study in 330 patients using medical thoracoscopy and TALP purgage and find exactly the same finding. In a lot of these studies of randomized trial, TALP pleurodesis consistently shows a success rate of around 70-something%. So not perfect. But also you need to remember, in most of these trials, patients who have short survival and patients with trapped lung are excluded. And we know that about 1 in 3 patients has got trapped lung if they have malignant pleural effusion. So the real-life success rate of TALP pleurodesis in every patient who walks through your door with malignant pleural effusion is going to be less than 50%. there has been quite a few randomized trials comparing TALC slurry versus IPC. And for those who are not familiar with it, indwelling pleural catheter are 16 French gauge silicone tubes that are inserted between the ribs, tunnel underneath the skin, and it's got a cuff that grows itself to the subcutaneous structures, and it comes out and ends with a one-way valve. And if the patient is short of breath, they can connect themselves to drainage bottles or drainage bags and can manage the fluid in the ambulatory setting. And the two most commonly cited randomized trials is the Time 2 study from the UK group published in JAMA, and also the Australasian malignant pleural effusion trial from my group, also published in JAMA. Both studies shows that IPC can improve the symptoms and quality of life as good as TALC slurry through chest tubes. So in our JAMA paper with 146 patients with malignant pleural effusion, we shows that if you treat the patients with conventional pleurodesis, they spend 11% of their remaining life, which is about 1 in 9 days of their remaining life, to be in hospital for whatever cause of hospitalization. But you can almost halve it to 6% if you use indwelling pleural catheter as the first-line treatment. And as I mentioned, TALC pleurodesis failed in about 20% of cases, so these patients require further pleural fluid interventions. But if you put in indwelling pleural catheter as the first line, only 4% of the patients in the study require further pleural fluid drainage. We then went on to look at how well can we manage the indwelling pleural catheter, and that's the subject of AMPO-2, which was published in Lancet Respiratory. What we found was that if we randomize the patient to daily drainage of the fluid versus drainage only when they're symptomatic, there was no difference in the breathlessness control or pain scores, etc. But if you drain the fluid daily, which means that you keep the pleural cavity very dry, there is a much higher chance of spontaneous pleurodesis. And the quality of life score was better, and in our subsequent paper, we shows that those people who have daily drainages of their fluid, their exercise capacity as measured by oscillometry is better than drainage only when they're symptomatic. The most interesting concept that has come in malignant pleural effusion in the last few years is the IPC Plus trial, where we no longer see IPC and TALC slurry as two mutually exclusive options, but if we combine them, we can get the best of both worlds. And this is the New England Journal published by the Bristol group, which shows that the TALC installation through IPC is feasible, is safe, and enhances pleurodesis. So how do we integrate all these exciting randomized trial data into one pragmatic single algorithm? So we've designed the epitome protocol, which is early pleurodesis via IPC with TALC for malignant pleural effusions. So you can see I spend most of my days thinking about acronyms. So in our group, in patients who have symptomatic malignant pleural effusions, all of them will have IPC as the default first choice unless there's contraindication, based on the Time 2 and AMPO-1 trials, and also the latest Optimum study. When the fluid is drained dry, we perform a chest X-ray to decide if the lung is fully inflated or trapped. If it is trapped, then IPC is the best option and the patient is discharged on symptom-guided drainage. If the lung is fully inflated, we adopt a modified protocol from the IPC trials protocol, where we keep the patient as an inpatient and use the TALC slurry protocol, including suctions, and we usually discharge the patient 24 hours afterwards. And then based on the AMPO-2 and the ASAP trial study, we perform daily drainages and then see how it goes in the next 2 to 3 weeks. If the drainage volume continues to decrease, we will keep on the daily drainages. And if the drainages decrease to less than 50 mL on 3 consecutive occasions, we can remove the IPC. So we tested it in 100 prospective unselected patients from our institute. And if the patient has got inflated or fully inflated lungs, they have a 74% success rate in TALC pleurodesis, which is very much in keeping with TALC slurry. And this usually occurs after a median of 20 days. This is the latest ATS guidelines for malignant pleural effusion. In PICO 3, it says that you need to have a large volume photocentesis to see if the lung is trapped. And if the lung is trapped, PICO 4 say that IPC or chemical pyrodesis can be first line. And PICO 6 says that if the lung is trapped, then IPC is better. So using the protocol that I just described to you, with IPC as the first line, it would simplify things a lot and satisfy all these ATS recommendations. But we don't need to do the large volume photocentesis to establish if the lung is trapped or not, because if the lung is trapped, we can talk through the IPC. If the lung is not trapped, if the lung is trapped, then IPC is already in place. So we save unnecessary procedures doing it this way. So the last thing left to compare would be to compare thoracoscopic VATS tout podrage versus IPC with tout slurry via the epitome protocol. So this is the subject of the ongoing Australasian Malignant Pleural Effusion or AMPLE-3 trial. This is supported by the Australian National Health Medical Research Council. We need 158 patients. As when I left Perth, we are 139, so almost there. So, and this is an effort of Australia, New Zealand, and a couple of centers in the North America. But the next step of the IPC journey is to try to see how we can manage the IPC better. Infection is the biggest concern deterring IPC uptake in a lot of centers. Our question is, can we prevent these infections by putting topical antibiotics around the catheter? Because peritoneal dialysis data has now shown that if you do that, you can significantly reduce PD peritonitis. So we just published a pilot study of 50 patients with IPC using topical milpiroxin. We find that it was very tolerable. So AMPLE-4 has just started, where we are randomizing patient who has an IPC fitted to have either prophylactic topical milpiroxin or Bactroban versus no topical antibiotics to see if we can provide prevention of IPC infection. This is the first effort. I can't guarantee it will work, but I think this is the important direction we have to head towards to try to find long-term prevention of IPC infections. And I'm going to finish here, and I'd like to thank my very hardworking clinical and laboratory group for generating a lot of the data that you have just seen. Thank you.
Thank you, Professor Lee, for that very comprehensive talk. Our next speaker is Dr. Rakesh Panchal. Unfortunately, he will not be able to join live online today, but his talk is going to be on medical management of spontaneous pneumothorax, current guidelines.
Hello, everybody. Good morning from the UK and good afternoon to colleagues in Sri Lanka. I'd like to thank the Sri Lankan College of Pulmonologists once again for inviting me to deliver this webinar. Unfortunately, I cannot be there with you in person, but I look forward to being with you in the future. So in the next 20 minutes, I'm going to talk to you about the medical management of pneumothorax based on the current guidelines. I have no disclosures or conflicts of interest with regards to this talk. So I'm based in Leicester, which is about 100 miles from London, at University Hospitals of Leicester, which is affiliated to the University of Leicester, on the bottom left, and my hospital, Glenfield Hospital, is in the bottom right. So in the next 20 minutes, I'm going to talk to you a little bit about pneumothorax risk factors, the evidence base for primary and secondary pneumothorax, ambulatory management, suction, a little bit about surgery, persistent air leaks, and illustrate this with the 2023 guidelines. So pneumothorax was first sort of described by Hippocrates, the father of modern medicine, where he described a Hippocratic suction splash when he was shaking patients with a hydropneumothorax. But it was actually Itard, who was a student of Laennec, who designed the stethoscope, who first gave a dissertation or description of pneumothorax. And then obviously pneumothorax became more common during the 19th century TB epidemics, when patients were developing bronchopleural fistulas. And Hans Jejard actually described pneumothorax in 1932. So just a bit of history about pneumothorax. So when we think about pneumothorax, we think about primary and secondary. We think about primary pneumothorax as those being patients with normal lungs, but actually these patients do have emphysema-like changes. And secondary pneumothorax is often older patients who are smokers who may have an underlying lung disease. And as you can see from this graph by Rob Halifax that there is a sort of bimodal distribution in primary pneumothorax, sort of those, as you'd expect, at younger age, and again in the older age, and in secondary pneumothorax, more common in the older age group. This literature from India, which is what I could find, unfortunately I couldn't find anything from Sri Lanka, shows that again, similarly, primary pneumothorax is common in the younger groups and secondary and older patients. And obviously the etiology is a little bit more different. In the Indian subcontinent, tuberculosis is a common cause of pneumothorax and obviously COPD as well. So how about risk factors? From medical school, obviously we all know the classical marfanoid features of patients which we'll look for. But pneumothorax increased risk in smokers, cannabis smokers, in the top right, patients who have tuberous sclerosis, diving, and obviously in the middle, there is a group of patients, for example, females who develop catamenial pneumothorax during their menses, often due to endometrial deposits or chocolate deposits, chocolate spots on their lungs. And then LAM, TB, and obviously anything that increases intrathoracic pressure. You have seen this slide before, and I think younger colleagues in the audience may be familiar with this boy band group, One Direction. And you'll be aware that the BBC News had this story a few years ago, and it was published as a case report that going to a boy band conference and screaming at the top of your lungs is a risk factor for pneumothorax too. So how about historical management pneumothorax? So Stradling in 1966 published in Thorax Conservative Management Pneumothorax. Then obviously guidelines have evolved in the 1993. People are advocating aspiration and drainage, and obviously we've become more interventional over the last couple of decades because chest drains have become more smaller. There's Seldinger drains, pigtail drains, as opposed to sort of surgical widebore drains. And then we had the BTS 2010 guidelines, and now we've got the new 2023 guidelines. We've become full circle, where we've sort of gone back to considering conservative management, ambulatory management, obviously needle aspiration, chest drain, which has always existed. So this is a survey of pneumothorax management in the UK, published by Rob Halifax. And you can see there's wide variation in practice. Again, 50% of clinicians with patients who have large pneumothorax who are stable with minimal symptoms will manage it conservatively, but patients who have symptoms and have a large pneumothorax, only 3% of clinicians would manage that conservatively. In about 2/3 of cases, clinicians will use suction if the pneumothorax isn't resolved after 2 days. 15% will clamp it prior to removal, 30% will never clamp it, and about a quarter might use some sort of digital suction device to measure the leak. So practice varies. So does size matter in 2024? Well, there's 3 sort of international guidelines. There's the American College of Chest Physicians guidelines, which measure the apex to the cupula, so the apical distance. The BTS, which have always advocated the size of a pneumothorax more than 2 centimeters at the level of the hilum. And the Belgians used to say if there's a circumferential edge to the lung, then that's a large pneumothorax. But there's no international consensus on size. There's the Collins and the Lights method of radiologically measuring the size of a pneumothorax, but there's poor correlation between that. So in 2024, we're focusing on symptoms and high-risk characteristics, and size alone is no longer thought to be an indication in terms of intervening in these patients. And if you do manage patients conservatively, perhaps we do need to follow them up more closely. So pneumothorax management. So aspiration has a success rate ranging from 50 to 80%. Chest drain will be successful in more than 70% of cases. And in those where it's not successful, we'll be referring these patients on for surgery. And our surgical colleagues will do pleural abrasion, maybe do a pleurectomy, talpoudrage, or excise these sort of blebs, which are often found. So when we think of primary pneumothorax, we think of patients having reasonably normal lungs, but they don't. You can see in this picture at the top that these patients often have emphysema-like changes with these subpleural blebs. And then in this picture at the bottom, this is thoracoscopy performed by Martin Norman in Belgium, where patients who had pneumothorax in the past, he gave them inhaled fluorescein. And when he changed from white light to autofluorescence thoracoscopy, you can see that there were actually defects in the visceral pleura, which gave rise to the theory of pleural porosity. Basically, there are areas in the visceral pleura where patients may be leaking air. And this probably forms the basis of our surgical colleagues doing pleural abrasion or pleurectomy in these patients. There's been 4 main studies in the last decade. There's the Brown paper published in the New England from Australia looking at conservative management of pneumothorax. the RAMP study by Rob Hallex, which is a British study looking at ambulatory management of pneumothorax, primary pneumothorax. Steve Walker's team in Bristol looking at ambulatory management of secondary pneumothorax, then a French study looking at aspiration versus drainage in complete pneumothorax. I'm going to talk a little bit about all of these in the next few slides. So, as I said earlier, Stradling published this paper in '66 in thorax. And again, interventional approach is currently standard practice, but if you go back 30, 40 years, conservative management was still around. So in this study, there was 120 patients who had a simple pneumothorax. About 80% had, 88 patients had simple pneumothorax. And in about 80% of them who were managed conservatively, the pneumothorax resolved by 4 weeks and almost 100% by 8 weeks. So on to the New England paper published in 2020. So this was an Australian study. It was a non-inferiority trial looking at conservative management versus intervention. So that was a 12 French drain for 4 hours, which is not really standard BTS practice. And their primary outcome was chest X-ray resolution at 8 weeks. And they found out, as you can see, in both the intervention and conservative group, there was no difference in the resolution, and that conservative management was not deemed inferior to intervention. And in the conservative arm, only 15% of patients required intervention. However, this study had a few limitations. It took 6 years from about 40 centers to recruit patients. It was about 8 per center, so about 1 per year. And they screened out about 88% of patients, including those who had a previous pneumothorax. Only 12% were randomized, so it was a highly selected population. Additionally, these patients had a longer duration of symptoms prior to presentation, so they'd waited for a while before seeking medical help. They had lower chest pain and breathlessness scores, and perhaps they were already a cohort who were less likely to require intervention and could be managed conservatively. And even if you go back to the 2010 British Thoracic Society guidelines, they'd always advocated that some patients with a large pneumothorax who've got minimal symptoms, you may be able to manage them conservatively and may not need to intervene. Looking at ambulatory management of pneumothorax, our group in Leicester first used the pleural vent and presented this at the ERS in 2015, and we performed this in both primary and secondary pneumothorax. And this was investigated further in the RAMP trial published in the Lancet in 2020 by Rob Halifax, which is a British study. So in this study, they looked at this device called a pleural vent produced by Rocket Medical. So this is an 8 French catheter with a pigtail with a Heimlich valve enclosed in this chamber, which is so it allows the collection of any fluid, and it's a one-way valve allowing air out but nothing back in, and it's inserted in the second intercostal space in the midclavicular line. It can also be inserted in the triangle of safety. But there are a number of different ambulatory Heimlich valve devices. There is also the Thorovent, which comes as in 11 French and 13 French. By Cook Medical, there's a Wayne pneumothorax catheter. There's these classical Heimlich valves, which can be attached to Selding or surgical chest drains. And there is also this device called a Peggy drain, which has been used in Southeast Asia. And you can also obviously use bags with a one-way valve attached to drains as well. So there's a number of devices to keep patients ambulatory. But ambulatory management is, again, not new. There's been a number of studies, but most of these have a high risk of bias. So the RAMP study was the first randomized controlled trial, which looked at aspiration or drainage, so standard BTS managed compared to the ambulatory pleural vent. And their primary outcome was hospital stay of 30 days, and they followed patients up to 12 months. And they found out that obviously if you inserted an ambulatory drain and the patient was fairly stable with it, they could be sent home and managed as an outpatient. In this group, patients tended to have, the study included patients who had a previous pneumothorax, included patients who were cannabis smokers, and these patients had high chest pain scores and breathlessness scores, so perhaps more akin to the sort of patients we see as an emergency admission. There was more adverse events in those patients who had the pleural vent device, but that's because they had a very strict definition of adverse event. So if there was any problem with the pleural vent and they had to come to hospital just for a review, then that was deemed a serious adverse event. But overall, it was considered to be a fairly safe device. So summarizing the two main studies, the New England paper from Australia and the RAMP study, the main take-home messages are stable patients can be managed conservatively, and that size doesn't determine treatment. And again, in the ambulatory arm, intervention can be based on symptoms, not size, and that ambulatory management works. And about 2/3 of patients can be discharged the same day and managed as an outpatient. So this is a quick case study. So this is a 35-year-old gentleman I had last year who works in an office. He's a non-smoker, doesn't smoke cannabis. And a week prior to seeking help, he was playing football, where he reports developing some chest pain, and he thought, oh, well, it's just I've strained a muscle. He was fairly well and came to see us at hospital. Early warning score was 0, and he was hemodynamically stable. So what would the audience do with this patient? Well, we have an ambulatory pneumothorax pathway, and I'm happy to share this with colleagues. We chose to manage him conservatively. He wasn't keen on having anything performed. He was very well, so we sent him home and gave him a telephone call every few days and saw him 7 days later. You can see the pneumothorax hasn't changed at all. Actually, there's a hydropneumothorax on the right. And at this point, he'd been off work and was keen to return to work and keen to return to sport. So he didn't want to stay in hospital. So we inserted a pleural vent. And you can see there's a little bit of reperfusion on the right side because the lung has been down. 2 days later, the lung remained up, and because it was a weekend, we saw him after the weekend, and the lung was up, so we took the pleural vent device out, and he had a good resolution. So how about ambulatory management in secondary pneumothorax? So the high-spec study, which was published in the ERJ, looked at, again, Heimlich valve compared to a 12 French drain. These patients were presenting to emergency departments. So if they had no drain inserted, they had a pleural vent put in. And if they had a drain inserted in the emergency department, they put a pneumostat device. So this is a chamber with a one-way valve which can be attached to a chest drain. But unfortunately, they stopped. There was an urgent safety review because patients who were having the pleural vent device, just under 50% were requiring a drain within a week. And they carried on using the pneumostat device. Unfortunately, the pneumostat is no longer available. So the conclusion from this study was that in secondary pneumothorax, pleural vent or Heimlich devices probably should be avoided, but the pleural vent is an 8 French catheter, so it's much smaller, and perhaps these patients have larger air leaks which can't be managed with such small devices. However, there is interest from the UK. This is a group in Kettering, near to Leicester, who used a 12 French drain and a pneumostat device in secondary pneumothorax. So perhaps in selected patients, you can manage them in an ambulatory fashion. So the French study, which I was mentioning, this was published last year and was about 200 patients. And they randomized patients to simple aspiration or drainage, and their outcome was lung expansion less than 2 centimeters at 24 hours. In those who had aspirated, about 30% had treatment failure, whereas obviously slightly less in those who had a chest drain. And the reoccurrence rates were slightly less if you had aspiration than if you had a chest drain. But they did use suction fairly early on, which is not common practice with quite a high pressure. And I suppose we still need to come back to, as Gary Lee, who's in the audience and has spoken on this symposium, wrote a supporting editorial saying we need to probably treat the patient and not the X-ray here. So how about pneumothorax reoccurrence? So there's this systematic review by Steve Walker from the Bristol group, looked at about just under 14,000 patients. And the 1-year reoccurrence was 32%, with the greatest risk being in the first year. Females have a higher risk, and perhaps if there's females and they have a history of pneumothorax, a family history of pneumothorax, we probably need to inquire about look for things like LAM. And we know smoking cessation is associated with a 4-fold reduction in pneumothorax rate. How about surgical referral? Well, the guidelines still say that if you get your second pneumothorax on the same side, or your first a second pneumothorax on the opposite side, then you need surgery. But there are patients who are divers, pilots who work in the military who would probably need to be referred to our thoracic surgeon colleagues after their first episode. We generally ask patients to avoid flying for 1 week after pneumothorax. As you know, the volume, if you have a pneumothorax in an enclosed cavity, so as the pressure drops, the volume of a gas in a fixed space gets larger. And obviously there's diving societies say that the patient should not dive unless they've had a definitive surgical procedure. How about surgery after first pneumothorax? So obviously there's high-risk people, so as I said, divers, pilots, those who work in the military. But the Ollison paper, which is a Danish study, looked at this, and in those who had VATS after their first pneumothorax, there was a 13% chance of having a further reoccurrence, as opposed to if you just had a chest drain, there was a 34% chance of having a further pneumothorax. But I'd say 13% is still high, 1 in 10 if you've had a surgical procedure. So they were saying that perhaps those who might derive the most benefits are those who have bully, more than 1 centimeter, or bleb, less than 1 centimeter and large dystrophic lesions. So this led to something called the dystrophy severity score, where if you've got blebs or bully, and if they're single or multiple or unilateral or bilateral, then you can get a score. And those with the low grade have probably a 50% chance of reoccurrence, but high grade have a much higher chance of 5-year reoccurrence, and perhaps these are the patients who require surgery. But I suppose we don't do CT scans on all patients who have had their first pneumothorax. And a British study also looked at this, and you can look at this in clinical medicine. In interest of time, I'm not going to go into this in much detail, but this is freely available in the Royal College London paper, and they had a nice algorithm there about how to investigate patients after the first pneumothorax. I'm going to finish a little bit with persistent air leaks. So you can use suction. There's large bore drains. There's autopleurodesis. You can use blood patch pleurodesis, talc, endobronchial valves, and obviously surgery. How about suction for pneumothorax? So suction involves the application of negative pressure. And the theory is you remove air quicker than the visceral pleural breach, facilitating resolution. But it's not routinely recommended by guidelines, and there's a chance that if you apply early suction, you may prevent the visceral pleural breach from healing and exacerbate it. And there's also a risk of re-expansion edema. But if you do use suction, it's important to use low pressure, high volume. How about digital suction devices? So there are devices such as the bottom, there's the Topaz drain, you can see here, which is produced by Medela, and Rocket Medical have also got the portable suction unit, which you can apply to drainage bottles. So this provides a continuous real-time air leak. It's quantified, you can set the pressure and it'll tell you what the flow is. The patient can be ambulatory with it, so they're not attached to wall suction with a bottle. And perhaps if the flow goes down, you can reduce the pressure, and you can use this to guide give an indication whether the pneumothorax has resolved and avoiding repeated x-rays. This has shown some promise in some pilot studies, and there is a British study going on which we're recruiting to called a RESPIRE trial, which is a randomized controlled trial looking at early resolution. So in patients who present pneumothorax, early suction versus standard management to see whether this helps. How about giving patients with pneumothorax oxygen, the nitrogen washout theory? So we know that the air we breathe contains 80% nitrogen. Oxygen diffuses readily into the bloodstream, and by giving 100% oxygen, the nitrogen will diffuse along a concentration gradient, and it will enhance the reabsorption of air. The evidence here is quite slim, actually. There's some reports in animal models, but limited retrospective studies in adults. So we do need an RCT to really answer whether giving oxygen therapy in pneumothorax works or not. So finding into the BTS 2023 guidelines. So as I said, these patients are focusing on the patient's symptoms and what the patient's priority is. So if the patient's not symptomatic, then you can probably manage them conservatively. If they have got high-risk characteristics, so they're hemodynamically unstable, they're hypoxic, they've got underlying lung disease, hemopneumothorax, then you may want to intervene with a chest drain. But as you can see here, the options are, does the patient want to avoid a procedure? Then you can do conservative management, but you need a mechanism of closely observing them. We try and see patients every couple of days, or give them a telephone call to see how they're doing and want to see them quickly if there's any symptoms. If the patient wants rapid symptom relief, but doesn't want to come into hospital, you can use an ambulatory device with a Heimlich valve like the pleural vent. But if they're not keen on taking a device home, you can do needle aspiration. And if that fails, there's always the option of chest drain. So how about ongoing and upcoming studies? So there is a British study which is ongoing now called CONCEPT, which is looking at conservative management again versus intervention. There's the PRINCE study looking at needle aspiration in secondary pneumothorax, because thought that some patients may resolve just with needle aspiration rather than putting a chest drain in directly. And perhaps these patients may be able to go home earlier. As I've explained, there's a RESPIRE trial looking at suction for early resolution of primary pneumothorax. And in hydrogen pneumothorax, there is studies which are going to be hopefully happening in the near future, looking at understanding how we manage pneumothorax after CT-guided lung biopsies. And there's the committed trial looking at conservative management in traumatic pneumothorax. There's this excellent resource which has been produced by colleagues in the UK called My Pneumothorax Journey. You can signpost patients to this. This is the website link, which gives, and there is a video as well, which will help patients understand the options available to them in managing the pneumothorax. So in summary, in primary pneumothorax, I think less is more. Treat the patient, not the X-ray. Conservative management may be suitable in selected patients. Symptoms guides patients and ambulatory devices may work. Ambulatory devices in secondary pneumothorax probably maybe in highly selected patients, but you want to avoid the pleural vent. A drain with a Heimlich valve may work. And I'd like to thank you for listening. This is I'm sharing some pictures from 2019 when I was with you for a meeting, and hopefully look forward to being with you guys again in Sri Lanka in the near future. Thank you.
Thank you, Rakesh, for that excellent talk, and I'm sure he will join with us when we have the discussion. So the final talk on the Pleural Disease Symposium is by Professor Vladimir Anikin. He is the Professor of Thoracic Surgery and Consultant Thoracic Surgeon from UK, and he's going to talk about place of surgery in diagnosis and management of pleural disease. Over to you.
Ladies and gentlemen, good afternoon. And first of all, I would like to thank the organizers of this wonderful meeting for inviting me here. Before I start my presentation, I want to say that I have no disclosure to make, and whatever you say, it's only my fault if you think I'm talking some wrongs. Pleural pathology interest in literature is substantial. Before this presentation, I made a short search in PubMed, and with the keywords of pleural effusion, I found this number of quotations. If you just expand the search for pleural only, it's coming, you see, to almost 100,000 publications. As a thoracic surgeon, when we are dealing with pleural pathology, we are involved in managing three main problems. It's a pleural effusion, pleural thickening, or empyema. We already heard absolutely wonderful talks before me, so my task is easier, and maybe if we find any discrepancies again, it would be entirely my fault. So the most common cause of pleural effusion, as we know, it's a heart failure, cancer, pneumonia, pulmonary embolism, and other pathology as well. The definition of malignant pleural effusion is straightforward. It's a condition in which we see accumulation of abnormal amount of fluid in the chest and found malignant cells in the pleural fluid. More prone for development of pleural effusion is patients with lung cancer, breast cancer on the second place, but effectively any cancer, any malignant tumor can cause this serious and dreadful complication. It's interesting dynamics of our involvement as surgeons in management of pleural effusion. I was doing a similar talk about 10 years ago, and you see about 10 years ago, our department in 1 year performed slightly over 1,000 procedures, and we managed with pleural effusion on 130 cases. Literally 10 years later, we see the number of procedures slightly decreased, but number of pleural effusions we are managing decreased more substantially. And if you see on the breakdown of pathology, we see we're far less dealing with mesothelioma and with metastatic carcinoma as well. Probably your colleagues in the United Kingdom, which are supporting and providing these referrals for me, they're doing well, so our workload has diminished. Literally any specialty can be involved in managing of patients with pleural effusion. It's thoracic surgeon, respiratory consultants, people with oncology, and any other specialty. So the basic physiology data saying that the mean rate of accumulation of absorption of pleural fluid would be 0.2 milliliter per kilo per hour, and then fluid should normally be replaced within 1 hour with complete turnover. Symptoms of these complications are numerous, but the main is dyspnea. However, some patients may not have any symptoms at all. But we need first of all to pay attention to other symptoms which may indicate other complications, other pathology, rather than pure accumulation of fluid in the pleural cavity. Physical signs are variable, but in our modern time, obviously diagnosis should not rely on them. However, it's always useful to investigate patients and do a standard physical examination, because findings may point out on something else which may significantly change the way you're managing a patient. The interval between the diagnosis and primary tumor and the presentation of pleural effusion may be very substantial. It can be several years, and the mean survival after presentation of pleural effusion would be approximately 16 months. Tumor time and survival with pleural effusion mainly depends on aggressiveness of primary cause, primary disease. We see that the worse for lung cancer, but it's reasonably long, over a year, in patients with mesothelioma. Also, pleural biochemistry can be indicative and prognostic, and we can predict survival to a certain degree, knowing that lower dehydrogenase and lower pH counting will lead to less, survival will be less with these findings. Investigations, I think they're mandatory, and the main investigation obviously should be chest X-ray, and then aspiration of the fluid, and obviously contrasted CT, which is the most helpful investigation for making diagnosis and planning the management. I want to remind you that plain X-ray, we can see the pleural effusion if the amount of fluid exceeds 200 mils. But if you do lateral view, occasionally you can see as less as 50 milliliters with blunting of costophrenic recess. Massive pleural effusion may lead to complete obliteration, complete whiteout of the hemithorax. And loculated effusion can conceal masses or look like masses on a chest X-ray. That's how it looks. Blunting of the left costophrenic recess in somebody with very small amount of fluid. And obviously the fluid can be bigger, compressing the lung with a little shift of the trachea to contralateral side. And it could be bigger, obviously, with complete opacification of the hemithorax we've already seen in previous presentations. CT scan, I think it should be mandatory investigation for people with pleural effusion, because it allows us not only to see the amount of fluid, see other things like nodular pleural thickening, presence of tumor, way of displacement, possibility to diagnose contralateral accumulation of fluid, and other findings. On a CT scan, to make diagnosis of pleural effusion is quite easy. We can see the fluid at the bottom of the chest with a meniscus, but it could be going into the fissure, as you can see on this patient, on this CT scan, in somebody with mesothelioma. Occasionally, you can see complete lobar collapse because of compression of the tumor, and in this case, you should always suspect possibility that the patient may have endobronchial pathology, which can contribute to such a finding. The role of ultrasound is critical for making, usually for doing a procedure, to putting a drain, to drain the fluid from the chest. As an individual diagnostic procedure, it has very little value, but it's very valuable as a tool for management of the effusion. People were investigating MRI but usually it goes as part of clinical trial, but access to MRI is limited, and usually it's not used to investigate patients with pleural effusion, but occasionally it may be useful when we want to, for example, to see how deeply pleural pathology goes into the muscle of the chest wall, so occasionally MRI may be useful, it could be used. When we are talking about indication for thoracic procedure, surgical procedure, first of all, we just need to think how to relieve dyspnea, prevent further complication, and think about expected survival of the patients, and try to improve quality of life of patients with pleural collections. And obviously, diagnostic component is also important. Ideal intervention, it's a no intervention, we'll always know, because any surgical intervention can cause problems, can cause even death. So first of all, we need to think whether we should interfere here or not. Unfortunately, more often than not, we have to. And in this case, we need to think about how long this patient will stay in hospital and how efficient, how effective would be our intervention as well, and potentially minimize cost of the procedure. Management algorithm is well known. We already see many pictures with that. It's more or less the same. Its effusion is symptomatic. Patient require aspiration with subsequent thoracoscopic intervention, most likely, or undwelling catheter. We can do a lot for pleural effusions as a surgeon as well, and as you as a respiratory physicians. It could be a pleural tap and drainage. We can do medical thoracoscopy and video-assisted thoracic surgery, open drainage, and even we can think about nodes procedure. Pleural tap, transient relief, mainly diagnostic, but it's unavoidable usually intervention as a first step in managing these patients. And usually, as we already discussed, it should be done ideally with ultrasound control to avoid iatrogenic damage to the lung. And we need to remember that you shouldn't really drain more than 1.5 liters in one go, otherwise it may lead to the expansion edema, displacement of the mediastinum, and other dreadful complications, potentially serious. Pleural drainage by itself, in several randomized controlled trials demonstrated that drainage without pleurodysys in malignant pleural effusion should be avoided because of high recurrence rate. And interesting enough, a small bore tube is the same effective as a big tube, a big chest drain inserted into the pleural cavity. Open drainage of the malignant pleural effusion and other type of effusions these days virtually never used, because it's people were suggesting pleurectomy and other major interventions, but mortality rate was extremely high, even with VATS pleurectomy in these patients. But occasionally we can think about it in specialist center, particularly in the fit patients, and failure to control the situation with other means. Thoracoscopy, we still need good performance status and inflatable lung, and it could be done with sedation or under general anesthetic. And GA can support lung re-expansion after the procedure. Modern thoracoscopy consists of two things. It's a medical thoracoscopy we heard about, and a video-assisted thoracic surgery. From my perspective, medical thoracoscopy can work in uncomplicated cases because it could be done with sedation at an outpatient settings. Instruments are small, but options could be limited. So if you run into trouble doing medical thoracoscopy, it's more difficult to control it. And you may do several procedures, hundreds of procedures, but in one day, patient may bleed, or other complications can occur, and it would be a disaster to control. We need to remember about it. Usually this procedure is done with semi-rigid instruments. We well know about it, and I'm not going to talk a lot about it because it's your domain. So when do we really need a surgeon? Often, because VATS is still gold standard to manage effusion and manage other pleural diseases, because it's the most versatile option and comfortable for our patients, because it's done under general anesthetic, and if necessary we can do a lot with thoracoscopes these days with instruments, even operate in complex cases or deal with unexpected problems which you come across during procedure. So that's how it looks like in real life. Massive involvement of the pleura, residual fluid, but you can see biopsy is planned. But in the same, also pleural effusion can be caused by very limited tumor burden, like in this case, in patient with a lymphoma, we can see only a solitary nodule on the pericardium without no involvement of pleura at all. Usually this intervention, we finish it insufflating talc powder to provide pleuradhesis. It looks like in real life, insufflated talc on the pleural surface and a biopsy site in the area around 3 o'clock. When thoracoscope is put and a large amount of fluid is detected, occasionally you may realize that parietal pleura is not involved at all. It looks entirely normal. And in this case, doing a biopsy of this pleura would be completely pointless. It would be normal. Like in this case, when in patient with a lymphoma, you see multiple lung deposits. So the plan of the surgery could be immediately altered, and this patient will require diagnostic wedge resection to obtain samples for histological examination. One of the trial, the authors tried to compare in prospective randomized trial thoracoscopy and talc insufflation and thoracostomy and talc slurry, and they found no difference. Another trial, another investigation was also done, and again, no significant difference in efficacy, time in hospital in patients with malignant mesothelioma in a retrospective study for surgical and medical pleuradhesis. Other trial, again, done about 10 years ago, it's demonstrated on retrospective review that video-assisted thoracic surgery, just simple tube thoracostomy with subsequent introduction of substance into the chest didn't make any difference, really. But significant difference, they say, in efficacy in this trial, so occasionally this research could be controversial. Undwelling tunnel catheter is good when fluid is accumulated in the chest and patient doesn't want to stay in hospital. But it requires serial drainage, and again, as we know, we've already heard from another speaker today, there's a risk of infection, including the dreaded complications such as an empyema in malignant pleural effusion. It's completely terrible and difficult to manage complication. Cost effectiveness. It's our American colleagues calculated that talc slurry is cost less than insertion of the pleurax. You see the comparison of both procedures, both interventions. But again, the amount of money you need to pay for pleurax drain is quite substantial, so it may be a limiting factor of using it as well. A NOTES procedure, this acronym states for natural orifice total endoscopic surgery. It was a big in vogue a few years ago, but now it's less developed. People started to lose interest to that. The idea would be to put an instrument either through the mouth and try to get to the pleural cavity using incision of the esophagus or on the stomach with subsequent closure of it. But again, it's done only in experiment, and I could not find any use of NOTES procedure just yet in real clinical life. Now I'm going to talk about pleuradisis because it's a part of our investigation, part of our procedures. You can see that surgical thought can go in a very twisted and interesting way. In 1935, when double lumen tube and the tracheal tube was not even used or invented, people using talc to produce adhesions in the chest prior to doing a lobectomy, because patient has to be ventilated himself or with a simple mask at the time of the procedure. So they use talc to introduce into the pleural cavity to create adhesions. And only in 20 years, intrapleural talc was suggested as palliative treatment for malignant pleural effusion. It was invented because it was a bypass of the because surgeon noticed development of adhesions in the bowel when surgical gloves were treated with talc. Pathophysiology of pleuradisis is simple. It's effectively creation of controlled inflammation inside the chest with all paraphernalia of inflammation we can see after the procedure. Pleuradizing agents quite various. It's surgical, medical, really anything which does exist in pharmacy can be used to create adhesions. But pleuradizis should be straightforward, should be easy to perform, and we need to try to minimize the number of complications we are expecting. Mechanical pleuradizis could be effective, but it's rarely used these days because still talc is the most common agent for this intervention. But as I said, bleomycin can be used, and tetracycline, glucose, iodine, you name it. I want to point to the iodine because talc should be contraindicated in case of a prolonged stay of a chest drain, if patient already coming from another hospital with chest drain, in an introduction of talc in the pleural cavity, which already partially infected, could be disastrous. Sterile talc, as I said, first of all, will use in 1935, and side effects includes acute respiratory failure. You need to remember about it, and it could be difficult to manage. And the question whether we should advise patient to roll or not after talc slurry introduced into the pleural cavity. This research demonstrated there is no point to roll, and it makes no difference for effectiveness of the procedure. Now I want to tell briefly about results of Mars trial in the United Kingdom. It was investigating efficacy of pleurectomy decortication against chemotherapy only in people with mesothelioma. And the results are very surprising. We found that no difference in survival in 42 months, and we found that patients after surgical procedure live not as good as after chemotherapy alone. So now we more or less stopped doing these procedures for mesothelioma. Another problem thoracic surgeon can encounter in people with pleural pathology is isolated pleural thickening. It always could be suspicious for mesothelioma and previous pleural pathology, but basically it's the same management as for people with pleural effusion. We can try to do VATS, But if the pleural cavity is completely obliterated, it may be necessary to do an old-fashioned open pleural biopsy, particularly targeting area, which particularly involved on a CT scan. Parapneumonic effusion, difficult to manage. It can turn into empyema. And as a surgeon, I can say, yes, you can do a lot to treat these patients. Very often patients respond, but if they don't, it could be a big, big problem. And I think with modern, safe surgery with video-assisted thoracic surgery, the earlier you consult the surgeon, the easier it would be to operate and better for a patient. So if you suspect early empyema, please talk to a surgical friend. Concluding my presentation, I can say that pleural pathology is quite common, and early involvement of a thoracic surgeon is strongly advisable, and VATS is a gold standard, our operating tool in this group of patients, and treatment obviously should be patient-focused. And thank you for your attention.
Thank you, Professor Anikin. As we are running short of time, we can just entertain one question from the audience. And the questions can be directed to any of the speakers who spoke in the symposium.
My question is from Professor Gary Lee. So with regard to the management of non-malignant pleural effusions, in Sri Lanka that we encounter hepatic hydrothorax and uremia, we have a large volume of patients with uremic pleural effusions due to underdialysis. Can we extrapolate the evidence of malignant pleural effusion for these patients, for symptomatic management of these patients with recurrent uremic pleural effusions and hepatic hydrothorax? Can we extrapolate the evidence of malignant pleural effusions for these patients?
Yeah, I think that's a very good question, and it is a topic I was asked to speak on last week in Thailand. The studies that has been done on these is actually quite small, as you know. I think if you have a recurrent benign pleural effusions, the most important thing is to find the underlying cause and treat aggressively the underlying cause. Diuresis needs to be aggressive, fluid restriction needs to be aggressive, and if you've got an underlying mechanisms that you can treat, then that is the best way forward. You also need to see if the patient actually got a symptomatic improvement from draining those effusions. Many people with heart failure pleural effusions, because the shortness of breath come from cardiac causes rather than from the pleural effusion, then it may not be worthwhile as much. It also depends significantly, at least in our setting, whether there are definitive treatments for the hepatic hydrothorax, which is obviously TIPS and liver transplant. If there is such options available to that particular patient, I'm usually a little bit hesitant to be too aggressive in terms of pleurodesis or indwelling pleural catheters, which are the options. And as you know, the indwelling pleural catheter does have a infection rate, which seems to be higher in the literature for people with benign pleural effusions rather than malignant pleural effusions. And I hate to take the patient off the transplant list because I gave him a pleural infection. So for those patients, I tend to do repeated thoracentesis in order to breach against transplant or TIPS. But if the patient is not a candidate for TIPS and not a candidate for transplant, then I think pleurodesis, if possible, and indwelling pleural catheter as a last resort. The reasons why pleurodesis will fail a lot of times is these patients has very high volume output, and therefore pleurodesis usually is not an option. So you need to, again, be aggressive with diuresis, aggressive with fluid restriction. And because hepatic hydrothorax is a result of transdiaphragmatic spread of the ascites, then keeping the abdomen dry may also allow you some time to try to make a successful pleurodesis. There is a small paper from South Carolina that shows that if you put the patient on CPAP after you give TOG for several days, which keeps the intrapleural pressure high, keeps the ascites at the abdomen and not flooding the pleural space, you can get a very successful pleurodesis. I've tried it for years, and there's very few patients can tolerate even low-dose CPAP 24 hours a day for the next few days after tau pleurodesis. So IPC now has become one of the options for these patients, and there has been a small randomized trial which shows that it is at least as good as for a therapeutic thoracentesis. But you do have to have a longer survival, longer time to use up consumables, and also longer time to develop pleural infection. So those are the trade-offs. So I usually use that as a last resort. Sorry for the long answer.
Okay, thank you very much. So we are concluding our pleural disease session. Over to you.
Thank you, speakers, for that informative series of presentations. Now, I cordially invite the chairpersons, Dr. Chandimani Undugurage and Dr. Afla Sadikin, to present the tokens of appreciation to the speakers. I would like to invite the speakers once again back on stage to receive their tokens of appreciation. Dr. Damit Nandadeva. Professor Gary Lee. Professor Vladimir Anikin. Thank you. Next up, let me invite the President of the Sri Lanka College of Pulmonologists, Dr. Bodhika Samarsekara, to present the tokens of appreciation to the chairpersons of this session. Thank you.